welcome everybody. This session, my name is William Levack. I am a professor of rehabilitation at the University of Otago in Wellington in New Zealand. I am a physiotherapist by background. This session, to get us started, is about rehabilitation evidence in low and middle income countries. And I'm joined by two fabulous rehabilitation physicians, Farooq Rathore from Pakistan and Abena Tannor from Ghana. I'm wondering if you two are able to just jump on, unmute yourself and put your videos on and say hello, introduce yourself. Abena, would you introduce yourself, please?
Thank you, William. So I'm Abena Tannor. I'm a PRM physician, a physical medicine and rehab physician based in Ghana, currently working as a consultant with the WHO Rehabilitation Program.
Wonderful, thank you. And Farooq, are you there? I can see Farooq, I can see your name there, but
Hear me now?
Yes, I can hear you now.
Sorry, can you hear me?
Yes, I can hear you well.
Okay, sorry. So probably some issues, my technical issues. So I am Farooq Rathore. I'm working as a rehabilitation medicine physician and consultant in Pakistan. I have been involved with Cochrane Rehabilitation since the inception. Basically, my background is in neurorehabilitation and spinal cord injuries, and also medical ethics and biomedical research. So it has been a fantastic journey of working with all these colleagues from different parts of the world, and it was a collaborative effort. And I'm really excited to be part of this collaboration, and I hope to contribute more and to sort of like gather more team members as we go along our fantastic journey of providing evidence-based rehabilitation services all around the globe. So thank you very much for inviting me.
Thank you. It's lovely to talk to you both again. I'm very sorry that we're not doing this in person, because I've always enjoyed talking to you both in person in the years that we've been able to get together. The topic of this presentation, as I've said, is around development and promotion of Cochrane evidence in low and middle income countries, and probably might be worth just highlighting to begin with that there is a high need for Cochrane evidence to be relevant to people in low and middle income countries, because one of the key aims of Cochrane is to have global impact and not just benefit a select group of people. And there's a high need for Cochrane evidence about rehabilitation to be relevant to people, and Cochrane evidence about rehabilitation to be relevant to people, because there's also a high need for rehabilitation in those countries as well. And Cochrane and rehabilitation, of course, is all about economic development, because it's about getting people back to work and helping people contribute to their families and communities as well. So I'm really excited to talk to you about this topic in a bit more detail. I'm wondering, Abena, would you be able to tell us a little bit about how you got involved in the Cochrane collaboration?
So I thank you very much, William. I have been involved with Cochrane Rehabilitation since 2017. I was invited to be a member of the advisory board, which was exciting because that was a time when I was actively promoting rehabilitation in Ghana, and trying to get more people interested, especially with physicians. Also at the time, I was also trying to start a rehabilitation fellowship program with the Ghana College of Physicians. And so it was really an exciting time, because rehabilitation for a long time, rehab medicine hadn't been really widely known in Ghana. We only had physical therapy, which had been in the country for about 10 to 15 years. But aside that, there was only there was no occupational therapy, no PRM physicians, there were no speech and language therapists. And so at the time, I think that it was welcoming news. And when I got the invitation and got involved in the advisory board, I came to actually also learn a lot about Cochrane, and also how to put the evidence into practice, how to apply it in the daily practice of seeing patients and helping to manage them. And so it's been quite a journey, and I must say, yeah.
Can you give an example of an activity or an action you've taken in your country to bring Cochrane evidence to rehabilitation services where you live?
Okay, so basically what I had been targeting, I have a background in family medicine, and basically started the first PRM training in Ghana. So my target had been to whatever meeting we have as a wider group, where we would have other rehab professionals invited, I would present an abstract, would be invited as a speaker, and it would be tailored at looking at our practice as rehab professionals and how best we could improve upon the practice. So one of them, I remember when I started my rehab journey, one thing that had been actually bothering me and I had been searching for actually was the use of bracing or using corsets or low back pain, managing low back pain. And I wasn't really finding any evidence behind that, but that was a common practice in my country. Everyone who came with back pain was being given a brace, a back brace. And so when I got the opportunity, what I did was to go to Cochrane, look at the evidence, the reviews, and then present on that. And I must say, I was quite pleased. People were surprised at what was coming out and the fact that this is not something that is the usual. It is not backed by really evidence does not really prove that this really works compared to not doing anything at all. And so that was a huge, I think to me was a huge achievement. Ever since, whenever I get the opportunity to present and also organize clinical meetings within the hospital I used to work in, we would pick one Cochrane review and we would discuss it and analyze the evidence.
That's a great example, actually, because it's an example. It's definitely a low-cost example to not do something that you don't need a resource. In fact, you're better off without it. So that's a really interesting example. Farooq, I'm wondering if you could give an example of a review that you were aware of having an impact in your country, either by reinforcing practices that were being used or by changing practices. Is there anything that springs to mind? You have to unmute yourself, Farooq.
Yeah, sorry. So can you hear me now?
Yes, I can.
Okay. So there was this interesting question that often popped up whenever we tried to treat patients with chronic back pain. So there is a trend in Pakistan that people use a lot of physical therapies, not active physical exercises, but physical modalities. So specifically ultrasound, therapeutic ultrasound is pretty common in Pakistan. And I used to see my colleagues, both physical therapists and many rehabilitation professionals who would advise therapeutic ultrasound for acute and chronic back pain. So ever since I got involved with Cochrane Rehabilitation and I got to know the value of reviewing and then adhering to this evidence-based practice, so I had this question. So surprisingly, I actually found a 2014 review on the use of therapeutic ultrasound in chronic back pain, which was recently updated back in 2020. So this often becomes a sort of a source of discussion and a starting point whenever I want to talk to my colleagues that what is the value of integrating evidence-based practice in your daily clinical care. So this is one example that pops into my mind, that it's a very common thing here, but whenever I talk to people and I use that systematic review as a sort of a template that, you know, the evidence behind this particular intervention is not very strong. So being a developing country, we should be focusing on interventions that are effective, backed by science, and which are also financially not very draining on the patient. And the good thing is that many of the young students and young physical therapists, the young graduates, they understand this message very well. And I do hope that once they go and try to explore that particular systematic review on the use of therapeutic ultrasound on chronic back pain, they also try to explore other options as well. And then they try to adhere to the ones that have been validated by a good systematic review, or maybe a meta-analysis, or even a randomized controlled trial. So this is one thing that just came up in my mind, the use of therapeutic ultrasound in chronic back pain. And I'm trying to change the practice here based on the evidence.
That sounds great. Are there other, sharing evidence from Cochrane Reviews at workshops and things sounds like a good strategy that's being used to bring Cochrane evidence to your countries. Farooq, are there other activities that you have been involved in to increase application of evidence-based practice in rehabilitation in Pakistan?
Yes, yeah. So again, I do a couple of activities both at individual level and sort of at societal level. So I'm a member of my society, Pakistan Society of Physical Medicine and Rehabilitation. So whenever I'm invited for a, let's say, talk at a local rehabilitation seminar or a local rehabilitation conference, so I make a point that many a times I actually use this opportunity to disseminate the evidence-based medicine and specifically the role of Cochrane rehabilitation. So for example, I have so far delivered 3 specific talks on the role of Cochrane rehabilitation in improving evidence-based practice all over the globe. In addition, I was given a chance to sort of lead a module on evidence-based medicine, evidence-based practice in physical therapy at one of the local universities 2 years back. So I actually, in that module, I tried to integrate specifically this Cochrane rehabilitation. And in one of the sessions, we all went online as a team using our own laptop and mobiles. And we explored this website of Cochrane rehabilitation. I gave them a little bit of quizzes and like tasks to do. And then they came back to me and it was fun, So in live exercise, I asked my youngsters to explore Cochrane rehabilitation. While I agree, I need to do more, but so far I have been able to at least reach out to the young faculty of physical therapy, occupational therapy, and rehabilitation medicine physicians. And probably this is the group that we need to focus more because these are the ones who are going to take the lead in years to come. So yeah, so I have been involved in a couple of individual and group activities.
That's great. There's definitely always more to be done, but it sounds like you both have already done a lot, I have to say. I'm wondering, just coming back to you, Abena, can you tell me a little bit about some of the challenges or barriers that you've faced bringing Cochrane evidence to Ghana?
So I think that with us being in a digital age, it's quite easy to promote it amongst professionals, although for those in the rural areas, for physicians practicing in the rural areas or in places where there's no internet, that is quite a difficulty or a challenge for them to get access to the internet to also use Cochrane Reviews in daily practice. So that has been quite a challenge, and probably looking at maybe we could find a way of download. It's difficult to download everything from Cochrane Rehab. And so that's something we may need to brainstorm about. The other thing has been sometimes the inconclusiveness of the reviews. And so sometimes you see that there isn't any evidence to show whether this works or does not work. And so you're sure, okay, so do I go ahead to use or not? Bearing in mind that rehab is not well advanced in the country, so people might not have enough experience from practice to say that this actually works. So even if the review is the recommendation or the review is inconclusive, from my practice, I think that this really works. And so that is one of the other things that have been like a big challenge for us also here in Ghana. Yeah.
Have there been times when you've come across reviews that are not relevant to your country, or they've been conducted in a way where the evidence doesn't relate to your country because of where the primary research was conducted?
Yes, so sometimes in terms of probably the equipment being recommended, the procedure being recommended, these may not be available in the country or might be expensive. And so people do not usually use. And so you're looking at, okay, you begin to think, how can I adapt? But when you start thinking about how to adapt, there is no evidence behind the adaptation. And so you're stuck in some place where you don't know how to apply what you're looking at and whether to adapt it or not. So sometimes the recommendations have either been not available in the country or might be expensive. The kind of recommendation being provided might be expensive for the person to provide or to afford.
Farooq, do you have any thoughts on this topic about the barriers or the challenges associated with implementing evidence in Pakistan?
Yeah, so I would rather say that these challenges are not specific to rehabilitation, but they actually apply in general to whenever physician or healthcare professionals, they try to follow the evidence-based medicine or evidence-based practice paradigm in developing countries. So as Abena has mentioned many things. So first of all, probably if you ask me, so the first thing is probably lack of training. The eye cannot see what the mind doesn't know. So if you don't train your people in critical appraisal of literature, the value of Cochrane, the value of writing and reading and evaluating a systematic review or a randomized controlled trial, probably this lack of training is going to be a major barrier in understanding what does evidence-based practice of medicine means and how to integrate that. Second, specifically in context of developing countries, another issue that I have often noticed is time constraints. Why? Because in most of the developing countries, the number of rehabilitation professionals is too low and the number of people with disability is too high. We don't get any time off. So like in the same time, when my colleague probably sitting in a high income country like Europe or Northern America might see 2 or 4 or 5 patients in that time, I will have to attend 20 or 30 patients, which means I will not find any time to actually go back, reflect on my practice and sort of like look for evidence base. Another issue is actually of institutional support. We don't have much institutional support in most of the developing countries. So for example, in many countries, access to Cochrane and other evidence-based resources, it requires subscription. And subscription need finances, and many a time a rehabilitation professional or any medical professional cannot actually arrange those finances out of his or her own pocket. Then even if sometime institutional support is available, there's a lack of understanding of at least the basic biostatistics. And again, it goes back to the way medical education and teaching is done in majority of the lower income countries. There are some really good institutes, but then there are not that great institutes. And if you don't have a little bit understanding of biostatistics, you might feel challenged that what this critical appraisal literature means, what these values mean, and what this graph means, forest plot and stuff like that. And last but not the least, as Abena just mentioned, many a time the challenge is, even if you understand the practice, even if you are convinced that this is something that we need to do, because of lack of resources or because of lack of other many things, you can't apply that evidence on an individual patient sitting in front of you. And that sometimes might become frustrating. So these are the sort of challenges that are in journal, but they do apply to evidence based in rehabilitation as well, from my perspective. Thank you.
Great, thank you. Abena, just thinking, I'm aware of the times, I'm just thinking, is there any things that you would like to see happen in terms of what Cochrane could do or Cochrane Rehabilitation could do in order to improve support for evidence-based practice in Ghana?
I think that first of all, probably if we could put together a small handbook or a short document on how to apply it in a low to middle income country, or short course where physicians can go through in low to middle income countries, can actually enroll, you get a simple certificate at the end. So by the time you go through it, you are well equipped to sort of use Cochrane Rehab within your country. We do have evidence-based medicine courses within the country, but I think that if we could have something like that within Cochrane, people would actually buy into it, because you are able to add it at the end of the year that you've undertaken a professional development course, and which is required to be able to as a yearly appraisal. So I think that would be actually the first thing. And then probably we may need to, evidence from low to middle income countries is lacking actually. And so I do not blame a lot on Cochrane, because we are viewing what is existing. And so as we run the course, as we look at that, people would also buy into doing our research in low to middle income countries so that we're able to generate more evidence that is applicable in our setting. Thank you.
I've got a couple of questions as a result of what you've said. I remember in the past, you talked about the value of print copy material for evidence, but also you talked about a handbook as well, that that print copy material is still very valuable because there's not necessarily the depth of penetration of internet through the country. Does that still apply?
Yes, it does apply, especially for physicians who are working in rural areas who do not have access to the internet. May have, but the cost of the internet can be also a barrier, and for all rehab professionals as well. So having print copies, very important, but I do appreciate the fact that that is also capital intensive. Printing and having to mail it to countries and all. But I think that once in a while, sending it over actually brings, and people having it in their departments, libraries, who can actually refer to. I think that actually also keeps people's minds constantly on the fact that looking at to evaluate their practice, is it evidence-based, and to remind them that there is Cochrane as well to rely on.
I guess one of the criticisms of that approach is that the evidence changes, and so it needs to be updated. However, some areas of Cochrane, it hasn't changed for a long time, like pulmonary rehabilitation. They withdrew updating that review because they got the same answer, and braces for low back pain, like you mentioned. That's not going to probably change anytime soon.
Exactly. So we need to look at, can we just start from the basic ones that do not change? Because you'd be amazed that people are still stuck in their old ways of practice. And so this can actually, it might not make an impact in a high income country, but in a low income country, it does make a huge impact.
I'm going to come on to you in a second, Farooq. I just want to ask you one more question, Abena, which is that you've talked before about the value of training local training as opposed to having going overseas to get the training. What's your view on people from high-income countries coming to provide training and evidence-based practice in your countries? What's the advantages and disadvantages of that?
I think the advantage is the new knowledge that they bring on board, but the huge disadvantage is the applicability of the evidence that is taught. Most of the times you would have people coming over teaching, but you need someone who is well versed in what happens on the ground, because a lot of the literature, what comes out in the literature is not applicable. You may recommend something which might not be available even within the country. And also, like Farooq mentioned, the time to even provide the intervention might not even be adequate. And so it would rather be best if we have trainer of trainers. So we train local people who will be able to look at it and adapt it, or look at, okay, how do I present this to the local people such that they would be able to apply? Because once you make the mistake of presenting something that is not applicable, people shut their minds off that, oh, whatever this person is coming to train on isn't applicable, so why bother attending? So we need to look at that as well.
There's some really clear guidance, which I really like. Farooq, what's your perspective on these topics, and is there anything else you'd like to recommend for Cochrane or Cochrane Rehabilitation in terms of supporting better supporting evidence in Pakistan, application of evidence?
Thank you. So, first of all, we need to, at least I acknowledge being a part of this global pool of wisdom that people from different parts of the world, continents, and all of them together for a single cause. So that's a great collection of individuals, right? And you all guys and girls bring in a lot of background and knowledge. So what I would recommend, probably it's time that we start sharing this global pool of knowledge and wisdom. And COVID-19 has clearly taught us that, things can be done and can be managed online. You don't physically have to visit a place, or you don't have to come if you don't have resources. So if you ask me, probably Cochrane Rehabilitation can actually start with small training sessions, online sessions, webinars, something like that. Maybe something as simple as critical critical appraisal of literature, how to read an article, what are the basic study design, why one is better than the other. Because again, because of the background, we assume that medical education and education of evidence base is uniform all around the globe. Unfortunately, it is not so. In many universities in my country, people would actually graduate and they still do not have any understanding of basic statistics or what evidence-based medicine means. So probably it's a good idea to hold webinars, seminars, training sessions. And as Abena mentioned, you can probably actually enroll and recruit and identify people from that particular country who can be then sort of like brand ambassadors of Cochrane Rehabilitation. So for example, I know that many universities are really good in producing good quality systematic review in Pakistan. So probably I can identify those individuals. Cochrane Rehabilitation can approach them officially, and they can be a brand ambassador or people who can then be helpful in promoting this message of Cochrane Rehabilitation in Pakistan and other developing countries as well, because we don't need to travel. We can manage everything online.